Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a couple of patients for you in this compilation video, and this is of patient 1 who attended with bilateral occluding earwax, and we're just commencing with this their right ear first. They noticed their symptoms whilst on holiday. They jumped in the pool and their head got submerged under the water, and subsequently upon exiting the pool they felt that their hearing had become blocked in this ear in particular, and it's not returned back to its normal level. So when you get water in your ear and you've got earwax, two things happen. The earwax itself can absorb the water. So 60% of earwax is made up of dead skin cells, exfoliated dead skin cells in the ear, and they're hydrophilic, so they absorb water, which causes the skin cells to swell, which can then enlarge the wax impaction and exacerbate your symptoms. And in addition, water can get logged in behind the wax. It can form into a puddle, almost like a reservoir of water. So these two things can affect your hearing if you do have earwax and you get water in your ear. It's quite a stubborn impaction. They do have to attend every couple of years nonetheless, and it's been around that 2-yearly mark. They do suffer from a bit of otitis externa, historically both of the entire ear canal and also the entrance, but on this occasion it was mainly at the entrance of the ear canal. So they have been managing their ear a lot better. They have tried to avoid water entering the ear, which is one of the triggers of otitis externa. So otitis externa is an umbrella term given to an infection or inflammation of the outer ear. The outer ear consists of the external satellite dish we all have on either side of our heads, the ear canal itself, and the outermost membrane of the eardrum. So the patient has been avoiding water entering their ears. They are using medical grade olive oil spray on a regular basis to help moisturize and lubricate the skin that lines the ear canal and eardrum to prevent it from drying and cracking. And on occasions they've been using acetic acid, so it's like a white vinegar, and acetic acid spray helps to reacidify the ear. It inhibits harmful bacterial and fungi growth, antimicrobial growth. So their overall ear condition has improved. But just wriggling this out near the entrance, they have got quite long hair strands here at the entrance of the ear, they're almost like whiskers, and because we've put some oil in, it can coat the hair strands, and it can also smear the lens of the endoscope. So I'm just trying to avoid that. You can see there's got this last impaction right on the eardrum, so we remove that away, and upon removing that last piece of wax they instantly notice an improvement. So that's the eardrum. There's a bit of sticky wax lining and coating the eardrum. We're going to leave that. It's not, you've got to weigh up the risk benefit ratio. Me trying to remove that bit of sticky wax in the eardrum is not really going to improve matters, and if anything, if we're not careful, we could perforate the patient's eardrum, which we certainly don't want to do. So I'm just mopping up near the entrance now. At the entrance, it's the outer third of the ear canal is made up of cartilage, so it's a lot less sensitive, it's flexible, so on that part of the ear canal we can apply a bit of pressure without causing the patient any discomfort. Same patient, this is their left ear. This ear was, I would say, 3/4 blocked, whereas their right side is fully occluding. This ear, however, was a bit narrower, so although there's less earwax, it was just as tricky to remove. I'm just trying to get through the narrowing and pull this away. You can see there's dead skin that's adhered to the ear canal wall, and it's also enveloped around the wax plug. I'm just trying to separate that. Past the second bend, so about a cent, your ear canal length is on average between 2.5-3 centimetres, give or take, and about a centimetre into the ear canal beyond the cartilage portion, so the inner 2/3, the bony portion of the ear canal. In this particular patient, it widens, so it's the cartilage part of the ear canal is quite narrow. Beyond that, there's a widening, and that's where the majority of the wax is. So we're trying to remove this larger wax plug through the narrowing in this patient's ear canal. So we're almost trying to defy physics here by doing this. Fortunately, the wax is soft. The cartilage is also malleable, so it does stretch slightly. So I'm just trying to roll this down and wriggle it and jiggle it through. And the wax plug is soft, but it's also firm enough to expand the ear canal, the cartilaginous portion, as we're bringing it through. This part got separated, I think, from the main blockage. Oh, no, it managed to tag along. You can see there's a bit of skin that's connected the top part of that wax plug against the bottom. That's the patient's eardrum. That's nice and healthy. Again, it's just a bit of debris around the edge. We're not overly concerned by that. We don't want to traumatise the bony part of the ear canal, in particular with the eardrum. So I'm just mopping up near this entrance. As we're bringing the wax plug through, it just coated and stained the ear canal. So this is patient 2. This is their left ear. Again, they have got quite long hair strands at the entrance, which can sometimes smear the lens of the endoscope, even because we're trying to get this through without making contact with the hairs, but there's so many, they are going to, unfortunately, come in contact. And when you're quite close to the hairs, you do get a reflection, as you can see there. Also, the reason why this is reflecting is this patient's got a lot of dead keratin, a lot of dead skin in this wax plug. Keratin is a protein that's found on the epidermis layer of skin, so the outer layer of skin in our ear. It's also a protein that we should have on our nails, fingernails and hair strands. And keratin is a very useful protein. It's hydrophobic, so it repels water, so it protects the skin from becoming macerated, and it helps the skin retain its internal natural moisture. Also, keratin helps to reflect harmful UV rays, so it is an important protein that we have in our ear and the surface of our skin and our fingernails and hair strands. The right ear, the plug came away quite easily, and this is their left ear. This is a bit more stubborn. We're just trying to get through those hairs, through those whiskers, and we're just then inserting the microsuction tube. We call the microsuction tube I use as a Zollner suction tube. It's a standard tube that we use. The diameter, give or take, is around 2 mil, 2.1 mil, and that's the outer diameter. The internal diameter is around 1.7 to 1.8 mil. So it's a very thin wall thickness. The made out of medical grade surgical stainless steel. They vary in length, so typically they're about, well, actually they don't, they're about 8.5 centimetres. The length itself about 3.5 centimetres from the distal lens to the tip. There's a 30-degree angulation which helps the insertion of the suction probe into the ear. Without that bend, it would be quite tricky. You'll just have a straight cylindrical tube going into the ear. That bend just helps, it provides you with more fine motor control. Nice and healthy eardrum. Well, I hope you enjoyed that compilation video, guys. Do take care, keep well, and speak soon. Bye.